This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, he is a 30-year-old man who has this presenile cataract. The cataract is swollen, intumescent, and there is a high risk of developing an Argentinian flag sign in these patients. Typically, the young patients have a low scleral rigidity and also a highly elastic capsule. These two factors have an important role in the way the capsule behaves, especially in such swollen lenses. Let's see how things work out in this particular case. So one thing which is quite positive is the appearance of these spokes in the cataract. These spokes also indicate that there is some amount of liquefied cortex, and this is advantageous in the fact that immediately as soon as we puncture the capsule, there is always gush of this liquid cortex out, which causes a spontaneous decompression of the bag. If the spontaneous decompression happens, then the chances of having an Argentinian flag sign are slightly minimized. Nevertheless, I'm going to take every precaution to ensure that I don't have an Argentinian flag sign in this case. The strategy is going to be, again, do a small primary rexis, decompress the bag, and then enlarge the rexis. That's the strategy. Let's see how things turn out. Important aspect here is to use a good quality viscoelastic. I'm using dispersive OVD to fill in the chamber, and this ensures that the chamber maintenance is good and the chances of the rexis running away can be minimized a little bit. I'm puncturing the anticapsule with the forceps itself, and as expected there is a slight gush of the liquid cortex out. Minimal amount of decompression, at least in the central area, has happened. The flap is grabbed, and the most important thing to note here is that the flap is kept flat, it's not everted. And using a tearing technique, gently I'm trying to create a very small rexis. My aim is to create a rexis about 3 mm, and I'm re-grasping the flap at very small intervals. I don't want to take a large tear in a single setting, so I'm keeping on leaving the flap, re-grasping, propagating the tear a little bit, and again stopping. As I feel that it is going out of control, again the flap is kept flat and pulled centripetally. This is one situation wherein I feel using the tearing technique to create the rexis is very helpful. That is in situations like this where the cataract is extremely swollen and we have got a young patient where the capsule is elastic. So finally I could achieve a small rexis which is just about 2.5 to 3 mm. Now is the time to decompress the bag. I'm going to use bimanual irrigation aspiration to decompress the bag. Again, little bit of a patience is required to go around all the corners, tap the lens, loosen the cortex and aspirate out. Care is to be taken not to be aggressive, because if we tug at this anticapsular margin, there is a possibility of tearing it again at this point. So we need to be aware of this. Just spending few more seconds and being patient and being very controlled with the maneuvers is going to be greatly beneficial. Once I am confident about the decompression of the bag, now is the time to enlarge. I'm using again OVD, which is being placed in the peripheral part of the antechamber so that it doesn't inadvertently go into the capsular bag and again raise the interlenticular pressure. I'm using a micro scissors to create a tangential nick here. Unfortunately, the nick has become wedge shaped instead of being a tangential cut. This is because of a faulty instrument. This wedge-shaped tear has a high risk of again propagating towards the equator. So I need to be careful when I'm enlarging it. I'm grabbing that one flap and then propagating the tear and doing it in anti-clockwise direction. It's important to understand now that although the wedge-shaped tear was highly vulnerable for extension, it did not, simply because the decompression of the lens was adequate enough. Because there is no interlenticular pressure, the secondary enlargement of the rexis could be possible with great ease. So I have a rexis which is about 4.5 to 5 mm in size, and this should be fine. The most difficult and the most critical aspect of the surgery was to get the rexis right, and it has come out well. So the next steps are going to be relatively easy to manage. Since it's a young patient, the nucleus is going to be extremely soft. So the one parameter which I'm going to change here is the power. So I'm going to bring down the power to around 10. And since this is going to be an extremely soft nucleus, I'm going to use the horizontal chop using a long Sinski hook. The power is set to 0. There's no power at all. I'm just with the vacuum itself trying to bury on the substance of the nucleus, and the chopper comes in. It's more of a mechanical fracture of the soft nucleus. The mechanical chopping itself splits the nucleus into two. Then it's quite easy. I'm going to engage the heminucleus with vacuum alone, and then pulling it out of the bag and then emulsifying it. The amount of energy which I'm using is just 5%. It is the same as what I use for my epinucleus management. So in these soft cataracts, once we get the first split of the nucleus, the individual heminuclei can be very easily pulled out of the bag and emulsified. The most important trick here is to use no power or very little power, because the moment we use power, we are going to bury and make a hole into the nucleus and we're not going to get any grip out of it. So best is to use very minimal or low power. Time to implant the lens. Using a hydroimplantation technique, the single piece hydrophobic lens is being placed into the bag.
He told that they have had cases where these lenses are also.
The OVD both in front and behind the lens is irrigated out. That's it, the case is done. And these are the first day pictures. So let me summarize and tell you the two important take-home messages here. In these young patients who have got these swollen intumescent lenses, the chances of Argentinian Flag Sign is quite high. And the trick here is to use a good quality viscoelastic which maintains the chamber, and then follow the principle of a two-stage rexis. When doing the rexis, it's important to use the tearing method when you're trying to create the first smaller rexis, because when the moment we try to fold the capsule and then try to tear it, there is always a higher risk of it propagating out of control and into the equator. So my preference is always to use the tearing technique rather than the shearing technique when you're trying to create the primary rexis. Of course, when you decompress the bag very well, when you're trying to enlarge the rexis, that's the time when we can resort back to the shearing technique. So these are the key points from this case. That's it. Thank you for watching and hope you found this helpful.